A very good afternoon, all of you students. I'm back here because I feel we should wind up the discussion on the opioids, and it's time now to read about the specific agents. We have already read about the classification of the opioids based on the source. We have read about its pharmacological actions, both central actions as well as peripheral actions, and now it is time to learn about the specific agents. So let us continue further, and students continue to read, because this is the time you can make up for the systems in which you are weak or you could not read in your semester because of illness or any other reason, wedding in the family. So make up most for this time, and that is my advice to you. So let us continue further with the opioids we know about, and we discussed the prototype drug morphine, and the discussion which was held in my previous sessions was more focused on morphine as a pain relieving agent, morphine as a drug which can cause peripheral as well as central actions. And now we would start with the second drug, which is also a natural opioid, and the name of the drug is codeine. Remember students, codeine starts with C, and remember two things for codeine, that is cough suppression as the main therapeutic effect and constipation as the main side effect. So let us go further. We will also be dealing with the synthetic opioids, pethidine, fentanyl, Methadone, dextropropoxyphene and tramadol. We'll also be throwing some light on the opioid antagonist, students. So let us go through first. Now coming to the specific opioid agents, and to begin is codeine. Codeine is not a very strong mu agonist, although it is a pure mu agonist, but it is not a very strong mu agonist. It is a moderate agonist, so that moderate agonism means that its intrinsic activity will be less than 1. It has a very strong cough suppressant action, and that I told is independent of its analgesic action. Its analgesic action is coming from morphine, because in the body codeine does get converted to morphine, and that underlies its analgesic effect. Its antitussive effects are unique to codeine, and they occur at much lower doses, or I would say sub-analgesic doses. It is less potent analgesic than morphine because of its moderate agonistic action, but it has a very high oral effectiveness. That is why it is given only orally, has a good bioavailability. It has a good antitussive activity at sub-analgesic doses that I have already talked about. It has lower potential for abuse than morphine, because whatever potential for abuse codeine is producing is via conversion to morphine, and that is dependent on one of the cytochrome enzymes, CYP2D6. So it does have lower potential to cause dependence, lower potential to cause euphoria, but it is associated with euphoria and dependence producing actions, and that is why it is not an over-the-counter medication. It is often used in combination with aspirin or acetaminophen, aspirin or paracetamol, and that is to enhance its analgesic effects. I told you in my discussion on the NSAIDs, like if there are two drugs which act by two different mechanisms, we expect synergism. So we expect synergism when we combine an opioid with a non-opioid. So that is the whole purpose of having synergism, because both will act via different pathways. NSAIDs will act peripherally, opioids will act centrally, students, and that is going to benefit the patient, will enhance the pain relief, and at the same time we might think of decreasing the dose of opioids. So combination is going to have an opioid sparing effect, and it has a good oral efficacy. I will not repeat again, and it has moderate to low affinity for opioid receptors. But mind you, it's a pure mu agonist. It's a pure mu agonist. Its conversion to morphine is brought about by the enzyme CYP2D6, and we had discussed in general pharmacology that this enzyme is subjected to genetic polymorphism, and the people who have less of this enzyme CYP2D6, they would not be able to perceive the analgesic effect of codeine, because morphine will not be formed. So that is about the people who and nor would they become dependent on codeine or develop any physical dependence, because morphine is not formed adequately in their bodies. So that is the relevance. And these are some of the actions of codeine. It's of course a very nice pain reliever. It is also producing sedation and drowsiness. It produces euphoria, maybe less than morphine, but codeine does get converted to morphine in the body, so we can't ignore this euphoria producing potential. And it is used for the management. It doesn't produce dry cough. It is used to treat, or it is used to suppress dry cough. So let us have the results of mu and kappa receptor activation. There are three receptors actually, mu, kappa and delta. And I have already told you in my previous session that mu mediates analgesia, kappa also mediates analgesia, delta also mediates spinal and supraspinal analgesia. Respiratory depression mediated only by mu, euphoria mediated only by mu, and physical dependence mediated only by the mu receptor, dysphoria mediated by kappa, and decrease in the GIT motility also mediated by both mu and kappa receptors. So why do we have to differentiate this at this point of time? The reason is that we are slowly moving to the drugs which are called the mixed agonist antagonist. What are these drugs which are mixed agonist antagonists? These are those drugs which will have kappa agonistic action and mu antagonistic action. They are called the mixed opioid analgesics. So what's a pure agonist? I told morphine and codeine are pure agonists. So morphine and codeine are going to be pure agonists at the mu receptors, and they are agonists actually at all types of receptors, mu, kappa and delta. What is an agonist and antagonist? Which will be an antagonist at mu and agonist at kappa. And pure antagonists will be antagonizing the mu, kappa and the delta receptors. So pure agonist, pure antagonist and agonist-antagonist combinations. Now if you talk about the agonist-antagonist combination, we have one of the drugs in mind here. The name of the drug is pentazocine, which is a kappa agonist and a mu agonist. It is a synthetic drug, and it has been put in place because if a drug is a kappa agonist, the analgesia will be attained, no doubt, but at the same time person will have less respiratory depression, and giving an agonist antagonist combination may not produce psychological and physical dependence. It is not associated with the reward properties because it is free from euphoria. Rather, these drugs are kappa agonists, so they might cause dysphoria, and those are unpleasant effects, and that will not allow a person to develop this habit out of reward-seeking behavior. And then there are some drugs which are called the pure antagonists, naloxone, naltrexone, which we are going to talk about later, students. So this is the classification for the opioid analgesics based on their receptor agonism, and this is from the Lippincotts. You can see the strong agonist L-fentanyl is a fentanyl type of a drug. It's not available in our country, but fentanyl is available. Heroin, which is nothing but dimorphine. Meperidine, which is in India, it is called pethidine. Methadone, morphine, oxycodone, remifentanil and sufentanil. They are used as general anesthetics, and they are strong agonists at the mu receptor. Then we have the moderate or low agonist, in which we have codeine and propoxyphene. Codeine and propoxyphene, which can actually be combined with paracetamol or aspirin for pain relief. Then we have mixed agonist antagonists and partial agonists. Here we have buprenorphine, pentazocine, butorphanol and nalbuphine. Remember that pentazocine is a mu antagonist and a kappa agonist. And what is buprenorphine? It is a partial mu agonist and a kappa antagonist. It's a partial mu agonist and a kappa antagonist. It is also used now for relief of pain. And we have the antagonists in the form of naloxone, naltrexone, and nalmefene. So students, you can also classify the opioids based on their receptor action as being having strong agonistic action, moderate or low agonistic action, mixed agonist antagonist agents, or partial agonists. Buprenorphine is a partial agonist and antagonists. Now this is the dose-response relationship. To students, we should not ever leave our basics of pharmacology and correlate everything with the dose-response relationship and correlate everything with the dose-response curve which each and every drug is supposed to produce. So these are the doses on this axis and the response on this axis. You can see fentanyl, buprenorphine, morphine, meperidine, and pentazocine. This is pentazocine response, students. And if you see here, which is the most potent mu agonist here, and you know potency is decided by the dose of the drug, number one, and which is the most efficacious. Let us come to that, which is the most potent and which is the most efficacious. I would not be wrong if I say fentanyl is the most potent and it is the most efficacious or efficacious as compared to morphine, because both are having the final maximal efficacy to be the same. You can see here the maximal efficacy of fentanyl and morphine is same, but fentanyl curve is on the left hand side, which means fentanyl is dose to dose more potent than morphine. Potency is decided by the dose, so less doses of fentanyl are going to produce very good analgesic effect produced with larger doses of morphine. If you see meperidine, which is nothing but pethidine, it also has a maximal efficacy which is quite close to morphine and fentanyl, of course little less, but yes, it is less potent than both the agents, fentanyl as well as morphine. If you see buprenorphine I told you is a partial mu agonist. What's a partial agonist? Partial agonist will have efficacy always between 0 to 1. If this we consider 0, this we consider 1. Partial agonistic is going to have an efficacy between 0 to 1. Although buprenorphine might be more potent than morphine, it might be more potent than meperidine, it might be more potent than pentazocine, but buprenorphine is a partial agonistic effect. And you see the ceiling comes with buprenorphine very fast, and same ceiling is seen with pentazocine. Pentazocine is less potent than morphine. It is less potent than buprenorphine. Of course, very less potent than fentanyl. And look at its maximal efficacy, which is very less as compared to buprenorphine, as compared to morphine and fentanyl. And this is because it is a kappa agonist. Kappa agonism does provide spinal and supraspinal analgesia, but this analgesia does have a ceiling effect. So we cannot do away with our opioids, the stronger opioids like fentanyl or morphine. We have to keep them in our kitty. Even if they cause respiratory depression, they are going to allay pain relief, or they are going to bring about pain relief in patients who really need it. So this is about the dose response curve of the opioids, and this explains everything, students. This explains everything. This explains that pentazocine is a mixed agonist antagonist having action on the delta, on the kappa receptor. Buprenorphine having a mu agonistic action and a kappa antagonistic action. So it's a partial mu agonist. That is why its final height is less as compared to fentanyl and morphine, students. This is the comparison of the maximal efficacy of commonly used narcotic analgesics. Codeine has low efficacy, moderate efficacy by pentazocine, nalbuphine and buprenorphine, and very high efficacy of these stronger opioids, fentanyl, hydrocodone, meperidine, methadone, morphine. These are all pure mu agonists. Pure agonists. I would say they are pure agonists. They will be having agonistic action on delta and kappa as well as the mu receptor. Now we come to another drug which is very, very popular. Students, up till now we have read about codeine, and we have also read about some different type of opioids with mixed actions, and they are primarily designed, these kind of opioids, they are primarily designed so that analgesic effect can be obtained, but at the same time person doesn't develop euphoria, person does not stand the risk of respiratory depression. So pentazocine, which is commonly available as Fortwin, is used as a post-operative analgesic, very commonly given because post-operatively patient is more prone to respiratory depression, so that respiratory depression will not be there with Fortwin. Of course, we will have the ceiling effects with Fortwin, but mind you, post-operative pain is of a moderate intensity. It is not categorized as a very severe intensity. Students, now we come to Meperidine. In India, it is called pethidine, and in a country like US, it's called Meperidine. It's a synthetic opioid, structurally unrelated to morphine. It's synthetic, it's not opioid, it's not natural like morphine. So sometimes, you need to differentiate between morphine and pethidine. Some type of questions are asked, compare and contrast morphine and pethidine, in which you will be comparing the drugs, how they are same, and then you will be contrasting them, how they are different from each other. So this is a question which belongs to the higher level learning, or higher, it involves synthesis of the mind of the students. He has to think and write. So let us have it priorly prepared before we go for the exam. Synthetic opioid, which is structurally unrelated to the morphine. It is used for acute pain, and pethidine can be a substitute for morphine for abolishing the pain of acute myocardial infarction. Pethidine has less passage across the blood placental barrier, so it is one of the drugs which is also preferred for obstetric analgesia. And pethidine has anticholinergic action. It doesn't have the bradycardiac producing action as morphine has. Morphine causes bradycardia. Pethidine is going to cause anti-muscarinic action. It is going to cause tachycardia. And pethidine has less spasmogenic effects on the sphincters of the body. I told you morphine constricts the pyloric sphincter, the ileocecal sphincter. It constricts the sphincter of Oddi, which is the sphincter of the gallbladder. So all these are having meperidine or pethidine has less spasmogenic effects as compared to morphine. It is definitely used for acute pain. It depresses the respiration similar to morphine. It does not have any significant cardiovascular action when given orally, and the reason is that it has a less histamine producing action as compared to morphine. So it has less histamine producing action, less vasodilatation. It increases cardiac rate, and that is attributed to its anticholinergic action. And because it is a mu agonist, it's a strong agonist at the mu receptor, it is also going to cause respiratory depression. Of course, less than as compared to morphine, or some books say similar to morphine. It also causes rise in the intracranial pressure, rise in the cerebrospinal fluid pressure owing to dilatation of the cerebral vessels because of carbon dioxide accumulation. It contracts the smooth muscles, especially the sphincters, to a lesser extent as compared to morphine. It can be given for analgesic for severe pain. It has no clinical utility in diarrhea and cough. So it is not used as an antitussive agent. It is not used as an antidiarrheal agent. Produces less increase in the urinary retention, less effects on uterine smooth muscle. Opioid commonly employed in obstetrics, well absorbed from the gut, so it is given orally, and useful when an orally administered potent analgesic is needed. So it can be given via the parenteral route also, but oral route is preferred. Duration of action is 2 to 4 hours, which is shorter than that of morphine. Why we say that? Because morphine, in the liver gets converted to another active metabolite, morphine 6-gluconide, which is a deceptive metabolite, because gluconide conjugation usually imparts inertness, usually takes activity away from the drug, but it is not the same with morphine. So its duration of action of morphine is longer as compared to pethidine or meperidine. So I think we had enough points to differentiate between the drugs, and meperidine is N-demethylated to normeperidine or norpethidine. An accumulation of this metabolite causes anxiety, tremors, muscle twitches, rarely convulsions, and this could happen if the person is taking larger doses of meperidine or he is on a MAO inhibitor for depression. So in that case, more of this minor metabolite will be found, which is norpethidine, and that is going to lead to convulsions. So I told you that some opioids are responsible for convulsions, although they do not have any direct CNS stimulant action. So here is about pethidine, which is a drug which is reserved for obstetric analgesia. It can be used as a substitute for morphine. It has less spasmogenic actions on the sphincters. It causes tachycardia vis-a-vis bradycardia. It causes less histamine release, so it causes less vasodilatation of the blood vessels. But yes, it can also produce respiratory depression. It is habit forming. It produces a sense of euphoria. Now we come to another important drug, students. The name is fentanyl. Fentanyl is one of the most lipid soluble opioids which are available. It is the most potent one, as you saw that its curve comes in very leftward on the dose response curve, not on the right hand side. More the rightward the curve is, less is the potency of the drug. More the leftward the curve is, it is more potent. So fentanyl stands most potent, and you know, it is so much lipid soluble. It is 100 times more lipid soluble than morphine, and so lipid soluble that we can be giving fentanyl patches for pain relief. It can cross the skin and permeate the skin and directly enter the systemic circulation via the transdermal patch. Fentanyl is also available in the form of lollipop, which when sucked in by the patients is a very good use for breakthrough pain. What is a breakthrough pain? A person who is taking round the clock analgesics for his terminal pain might experience periods of breakthrough, and to decrease his pain or to relieve his pain, we might have to give an analgesic, added doses of analgesic, which is going to provide rapid pain relief, and fentanyl does the job. So fentanyl is having very important uses to play. Although fentanyl is a very potent respiratory depressant, even its transdermal patches have caused respiratory depression. But all said and done, it is one of the most superior opioids we have. It's 100-fold the analgesic potency of morphine. It is used in anesthesia, and it is very highly lipophilic, rapid onset, short duration of action of 15 to 30 minutes. It can be injected IV, epidurally, or intrathecally. I told you it can be sucked via the buccal mucosa, and these are the preparations. Oral transmucosal preparations are available. Transdermal patches are available, and this transdermal patch is going to provide the reservoir of the drug from which fentanyl is going to get absorbed into the systemic circulation and produce the effects of pain relief. It has few cardiac effects, and that means it has less histamine producing potential, but because it is a very strong opioid, it is going to cause chest rigidity, abdominal rigidity, chest rigidity, so that is going to compromise on the respiration, as I told you, and life-threatening hyperventilation has been seen even with the fentanyl patch when it was used in the management of acute and post-operative pain. So we have to be very careful about the respiratory depressant producing potential of fentanyl. So let us have this picture. This is in the form of a lollipop. It's a transmucosal form of fentanyl, which is delivered to the buccal mucosa in the form of lozenge that the patient can suck on. This is especially for the breakthrough pain, and this is a matrix which contains fentanyl, and it quickly dissolves in the saliva. You know that buccal mucosa is richly innervated with blood vessels. It is directly absorbed by the buccal mucosa, and it brings about pain relief. You should know which are the drugs which are meant to be given to be absorbed directly via the oral cavity. One of them is crystal trinitrate, isosorbide dinitrate. Even now we have sublingual B12 medicines which are also available sublingually, and we must make a list of those drugs which can be given sublingually. You can see the onset of action is 5 minutes, a very rapid onset of action if given intravenously, and the duration of action is 15 to 30 minutes. Onset of action of morphine takes long time, 20 minutes, and duration of action is also longer because it gets converted to another metabolite, morphine 6-glucuronide. Same with meperidine. Meperidine duration of time to peak effect is little less than morphine, but its duration of action is lesser because it does not form an active metabolite, 2 to 4 hours. Then we have methadone, students, and methadone, don't confuse it with morphine. Methadone is a very potent drug. Yeah, it's a long-acting mu receptor agonist. If the drug is long-acting, means its onset of action is going to be long, and because its onset of action is going to be long, its euphoria-producing potential is also going to be delayed. So methadone is not going to produce that instant euphoria which the opioid addicts seek, because it is going to have a onset of action which is a little bit longer. It will not be an instant euphoria. So that is why methadone is used for the management of opioid de-addiction. Let us go further. It's a very long-acting mu receptor agonist. Not only it's pharmacokinetically long-acting, but see, the duration of action is 15 to 40 hours. Vis-a-vis morphine, its duration of action is 6 hours. Vis-a-vis fentanyl, duration of action is 1 to 2 hours. So it has a long duration of action, and it is 90% bound to the plasma protein. So students, we go back to general pharmacology, where plasma protein binding of the drugs spares the drug from being metabolized by the metabolizing organs like the liver. So drug stays in the body for a longer time. The drug which is more bound to the plasma proteins will have a longer half-life. In most of the cases, it's like that. And it has a good analgesic activity. It can be given orally, and its extended duration of action is its unique feature, and that helps in suppressing the withdrawal symptoms in physically dependent individuals. So it is used for morphine treatment of morphine de-addiction or morphine withdrawal. It's a gold standard because once a person is to be taken into a de-addiction center who has taken morphine-like drug, he has to be actually now be de-addicted. He has to be mentally prepared for de-addiction, and suddenly we cannot deprive him of the opioids. If he is taking heroin or fentanyl as a drug of abuse, he has to be given some opioid for the time being for some few days so that his withdrawal symptoms are not severe. So methadone will do the job. Of course, methadone is also dependent producing, habit forming in nature, but yes, it is given to soothe out the withdrawal. It is given to an addict soon after he plans for withdrawal, and methadone maintenance therapy is given for about a fortnight, and then methadone is also withdrawn. Finally, the patient is sent home. So methadone is used for opioid maintenance therapy. This function of methadone, that is for opioid de-addiction, is also now taken over by another weak or partial mu agonist, buprenorphine. So because they produce less severe withdrawal, the withdrawal with methadone and buprenorphine is more protracted. You know what is the shape of a protractor? It's like a D. So it's a protracted withdrawal. It is not a sudden withdrawal which is going to be inhuman to a person who has planned for de-addiction. So withdrawal, doctors have to help the patients every time. Okay, even if the patient is into something which is illegal, say for opioids or something, his withdrawal has to be soothed out, because doctors are seen next to God by the patient. We cannot allow him to, suffer that he has been taking this opioid, he's a culprit or he's a drug abuser. We let him experience those withdrawals. No, we have to soothe him out. That is what is the role of a doctor. So we have to go for methadone maintenance. Why methadone? Why not heroin, or why not codeine? Why methadone? The reason is its long duration of action. It's tight binding to the mu receptor. You know, if a drug is tightly bound to the mu receptor, it will be occupying the receptor for a long time. Person will have less signs of physical withdrawal, will be smoother, and he won't get the kick also, because the drug is tightly bound, its onset of action is quite late, so instant kick will also not be perceived. But yes, methadone will maintain the basal levels of the opioid in the body, which is not going to cause a very severe withdrawal. So that is the reason this question is asked as a short note. This is foundly bound to the tissues, including the brain. It on repeated dosing, it is dosed in the dose of 30 milligram, accumulates in the tissues, and administration discontinued, low concentration is maintained in the plasma by slow release from the extravascular binding sites in an addict. It's relatively mild but protracted withdrawal syndrome, which lasts from days to weeks, and it is equal in potency to morphine but induces less euphoria because its onset of action is delayed. And if you see the efficacy and addiction liability of these drugs, you can see here that morphine efficacy is at par and its addiction liability is also at par. Meperidine efficacy and addiction liabilities are at par. Same is for methadone. So person does have addiction with methadone, and same is with fentanyl. So but codeine and propoxyphene, they are weak mu agonists, so they have less efficacy and at the same time they have less addiction liabilities. Yes, efficacy, but yes, addiction liability because codeine gets converted to morphine only in the body, so but on the lower side. Yeah. Now let us have a question. Which of the following opioids is so lipophilic that it is marketed as a skin patch used to treat chronic pain? Morphine is not marketed as a skin patch and it is not so lipophilic either. Naltrexone is not an opioid, it's actually an opioid antagonist. Scopolamine is marketed as a patch, but that is for treatment of or prevention of motion sickness. Methadone is available in the form of tablets, and the only drug which is so lipid soluble, which can be given in the form of skin patch, transdermal skin patch, the answer is fentanyl, students. Then there are many drugs which can interact with the opioids. Some will cause additive CNS depression if the opioids are combined with the sedative hypnotic drugs like the benzodiazepines, or they are combined with antipsychotic drugs like haloperidol, which have significant sedative action, or trifluoperazine or chlorpromazine for that matter. If it is combined with tricyclic antidepressants, amitriptyline and imipramine, they are also having H1 blocking action in the brain. That is why they are highly sedative in nature, so they can cause additive CNS depression. As I was talking about meperidine, meperidine usually gets metabolized by the MAO inhibitors, MAO enzyme. So if the patient is on a MAO inhibitor, then its other pathway which generates norpethidine, which can cause convulsions and cause hyperpyrexia, can come up. So meperidine should not be given along with the MAO inhibitor. This is only in relevance to the meperidine MAO inhibitor drug-drug interaction. This is for additive CNS depression. These are for additive CNS depressive effects. Now we come to another question, which is about a heroin addict. A heroin addict enters a rehabilitation program, requires that he take methadone. Okay, so he will have to be put on methadone or buprenorphine. Methadone is effective in this situation because it is an antagonist at the morphine receptors, has less potent analgesic activity than heroin, is longer acting than heroin, does not cause constipation, is non-addictive. So let us go to the first, which is why methadone is more effective. Is an antagonist at the mu receptors? No, it is not an antagonist at the mu receptor. Naltrexone and naloxone are antagonists at the mu receptor. And if you give an antagonist for withdrawal, you are going to precipitate a withdrawal. You are going to make the patient's life miserable. So you don't qualify to be a doctor in that case. It has less potent analgesic activity than heroin. No, heroin is very lipid soluble. It is more potent, so it doesn't have a less potent analgesic activity than heroin. It does cause constipation. After all, it is an opioid agonist. It's a pure opioid agonist. It is addictive in nature. Patient might become methadone dependent also. But yes, the reason why it is given to an heroin addict is longer. It is longer acting than heroin. Heroin is shorter acting. The kick is perceived immediately. But this is not the case with methadone, where the kick would not be perceived so immediately. So it is longer acting than heroin. It binds to the mu receptors very tightly. It also binds or accumulates in the extravascular tissues. So because of that, even if you are discontinuing methadone, the levels of the methadone stay in the body, and that decreases the craving which the person feels because he is not able to procure or take the drug. Now we come to the tolerance and dependence. I told you the mechanisms of tolerance, and this was more in relation to the analgesic effect, that we would require higher doses of analgesic effect. We might go for the opioid rotation policy if the person becomes tolerant to the effects of the opioids. But here we are going to discuss the tolerance and the dependence. We are going to treat the opioid dependence. So if the person is not to be given an opioid, he is going to have withdrawal or abstinence syndrome. I told you, in a setting of a drug, the body enters a new hemostasis. And if the drug is withdrawn, there are going to be tremendous withdrawal symptoms. These withdrawal symptoms are sympathetic in nature, as well as opposite to the offending drug or the drug which the person is taking. Sympathetic stimulation occurs initially. The sympathetic symptoms are very marked. They are characterized by anxiety. They are categorized by tachycardia, rise in the blood pressure, because the person knows he will not be given the drug. He is in a rehab center. He knows that he won't be given his drug. That itself produces a lot of anxiety, produces a lot of sympathetic stimulation, and that has to be managed by sympatholytic drugs in the form of clonidine. Clonidine eases out the withdrawal, and it is not only just reserved for opioid withdrawal. Clonidine can be given for various other drug withdrawals because of its sympatholytic action. The other type of effects which a person who is now not taking an opioid, who is now going into a de-addiction center, would be the effects which will be opposite to the effects of a drug which he was taking. So let us go further and study about the drug withdrawals. The opiate withdrawal, is not life-threatening but associated with severe psychological and moderate physical distress. There are so many actors. Classical example of Sanjay Dutt, who has admitted that he was taking a drug of abuse. It was an opiate, and his withdrawal, it was shown in the movie Sanju, and you could perceive that withdrawals are very, very severe, but they are not life-threatening. The onset of withdrawal symptoms occurs not in 2 to 3 hours, but yes, occurs in 8 to 16 hours after cessation of the use of heroin or morphine. I told you the autonomic disturbances, the sympathetic stimulation does happen. Person does have tachycardia, rise in the blood pressure, anxiety. All those symptoms, they appear first in a patient. These effects peak within 36 to 48 hours, like 36 to 48 hours are very crucial, after which most of the signs and symptoms gradually subside. By 7 to 8 days, most of the effects have disappeared, and some may persist for months. So let us see that the patient has gone in for opioid withdrawal, and what is up to 8 hours, stage 1 of withdrawal. He is going to have anxiety because he's not going to get the drug. He's going to want the drug craving, as we call it. Then in the stage 2, he will have the symptoms or signs which are opposite to the drug. Morphine causes sedation, so person is not going to get good sleep. Morphine causes constipation, so person is going to get diarrhea. Morphine causes pinpoint pupil, person is going to have dilated mydriatic pupil. Morphine has a calming down effect, person is going to have anxiety and lot of sweating and rhinorrhea. See, these effects, insomnia, anxiety, mydriasis, are opposite to the opioid action, and that is what we have to appreciate. As we go further up to 3 days, there is going to be tachycardia, there is going to be nausea and vomiting, there is going to be rise in the blood pressure, diarrhea, opposite effect of morphine usage. There is going to be myalgias and muscle spasms which have to be managed by NSAIDs. There is going to be seizure because morphine are CNS depressants basically. So removing morphine from a person's life is might predispose him to seizures, tremors, goose skin or chills, and rise in the body temperature. There is going to be hypothermia. So Methadone is a commonly used replacement medication in the doses of 20 to 40 milligrams per day, and after 2 to 3 days of stabilization, the dose can then gradually be tapered over 1 to 3 weeks and the drug is stopped. Clonidine has to be started immediately, and that is to be given 0.1 to 0.2 milligrams every 8 hourly, and then it is also tapered over a period of 10 to 14 days. Clonidine is for the sympatholytic action. It decreases the cravings associated with various drug withdrawals, not only just morphine. Non-specific treatment for prevention of convulsions, we will be giving the benzodiazepines. For his anxiety also, it will take care of the anxiety and will bring about sleep. There's going to be a lot of diarrhea in this patient, so you will give an anticholinergic with an antihistaminic with an anticholinergic action. The drug is prochlorperazine, and propoxyphene, which is a weak mu agonist, and or NSAID can be used to help with his muscle aches and myalgias. Now students, we go to another group of drugs which are called the mixed agonist antagonists and partial agonist. I think we can do that in our next session, and for now I think we do stop here for a while, and students, please continue to read, and that is important for you at this point of time. Thank you so much, students.